Welcome to a CME podcast episode from NEI, the Neuroscience Education Institute, hosted by Dr. Andrew Cutler. For complete CME information, please refer to this podcast's description page or go to nei.global/podcast.
Hello and welcome to another NEI CME podcast, and today we're going to be talking about complex depression, treating beyond the standard algorithm. With me today, I think, are two experts in the field. Dr. Stephen Stahl. How are you, Steve?
Great, Andy. Glad to be here.
Super. And of course, Dr. Roger McIntyre. How are you, Roger?
Andy, always fun. Great to be with yourself and Steve for the conversation.
I agree. So let's start off here by just talking about some terms here. When we think about complex depression, what does that look like in clinical practice, Steve?
It's a catch-all phrase. It means somebody I haven't treated well. It means somebody that's got residual symptoms that I don't know what to do with. It can mean I've taken one medicine and failed. It can mean I've taken 3 medicines and failed. It's kind of a garbage term, quite frankly. It's come to mean perhaps a few specific comorbidities that might actually have a biological basis that would allow differentiation of treatment.
Roger, what do you think?
I agree with Steve. I think I kind of see it two ways. And first of all, I start off by saying as a descriptor, I don't find it particularly exact or particularly specific, but but I think the way I conceptualize that complex depression, you could sketch the portrait of the depression in terms of the severity and the comorbidity and some of the specifiers. Secondly, just inadequacy of the treatment. Often people who have a very malignant depression, it's often labeled as complicated in the sense that it's not benefiting from the usual, first-line antidepressant. I think, it's like treatment-resistant depression, Andy, which is another sort of moniker. It's been around for decades, probably not that, well, it's not very exact, and it probably not even very accurate in many cases. So I think words do matter. But I think it describes this complexity of disease state and uncooperativeness of the illness to treatment.
Another way to do it, is to think that this might be the mental health professional's depression, in the sense that there's so much depression, it's the common cold of psychiatry, that much of the lifestyle-related, I've got stress at work-related, relationship, spouses, like children's, more mild to moderate depression, which is just rampant in our society. That is treated. We never see it maybe because it gets treated successfully by primary care. So when it fails primary care, it kind of bubbles up and to us, and it's and then people listening to this podcast, and so we see the referral patients that are basically not treated. I don't know, when's the last time you saw a patient off essentially, we'll call it an antidepressant virgin, that in their first episode that's never been treated before? That's just not what psychiatrists and mental health professionals see.
I like that point, Steve, in the sense that, Andy, we can talk more narrowly about the entity itself, depression, how complicated, in quotes, it is, and how uncooperative is the treatment. But I think what Steve spoke to, the word insecurity comes to mind, or precariousness, with respect to their housing situation, their healthcare access, their economics situation, their food access and security.
Job.
In other words, exactly, this sort of determinants of health. So when I see someone who's had a first depression, so common for us to hear one or more of these areas of insecurity. By definition, that becomes a complicated depression, but that's more of an environmental, social, economic sort of circle around the organism of depression. So I think depression can be very narrow. It can be sort of broader, sort of ecosystem, and it can be therapeutic.
I think what this also brings to mind is the heterogeneity. I almost have a problem calling this one thing depression. It just doesn't seem to be very accurate.
I think we have this problem in mental health in general. Take schizophrenia. There are trajectories. Some people have one episode of psychosis and then they kind of don't. And then some people just have a few and they go to community mental health centers and are moderately ill. And then there are people that you see that are homeless and in prison. So, the same thing when you say depression, it's just not very useful as a term. So if we can use a term, I don't care if we call it complex or whatever, we're talking about this is the trajectory of people that are sick enough, as Roger just said, to have environmental things that, I mean, the average person with depression doesn't necessarily lose their job and have an inadequate response to an antidepressant. But those are the people that we see.
Yes, good point. No, we do tend to get the harder cases, but when we talk about heterogeneity, I'm talking about schizophrenia is a good example. Some patients with schizophrenia have predominant positive symptoms. Some present with predominant negative symptoms. Some have more or less degree of cognitive impairment. Same thing with depression. You know, guys, when I was in med school, I'll never forget realizing, you mean it's the same thing if I sleep too much and eat too much, or if I sleep too little and eat too little? That's the same thing?
Right.
And of course it's not.
Right.
The other thing we have to confront here is what we've started out talking about in my mind is the syndrome of depression, which is a major depressive episode. That's not a diagnosis, guys. And I think because the terminology, we got a problem here. We use the same word, depression, for a syndrome and a diagnosis. And then we have this class of drugs called antidepressants. But if it's bipolar depression, of course, that's treatment. So how do we think through that conundrum that we're really talking about a syndrome here? How do we sort through what's
How
really
about
going
talking
on?
to your patient and map every symptom they have?
Okay.
And if they have symptoms that are outside the diagnostic criteria, guess what? You treat them as well. That's one of the problems, is that these carry-along symptoms, we'll get to it, you know, if you're manic and depressive at the same time, or if you have really bad anxiety, why do those come to our attention? Because the treatments don't work for them. Everybody gets, 16 million antidepressants in the SSRI class are prescribed every year. You know, guess what? They work, except if you have some of these additional symptoms, and then they're left over. And so you have to ask people, beyond just the diagnostic criteria, all the symptoms they have.
And the comorbidities, I would argue, too. Yeah, the fact this is such a heterogeneous illness brings up that to think that one mechanism is going to treat all of this is so naive. And the good news is we have newer medicines being developed, discovered,
Sometimes
approved.
you get more than one medicine?
Oh.
Oh, my goodness.
Unfortunately true, yes. Okay. So how do we approach the diagnosis of patients who don't necessarily fit the textbook profile of MDD, let's say? Let's say those who have comorbidities or treatment resistance. I mean, let me put it this way, Roger. So you mentioned treatment-resistant depression.
Yeah.
Isn't it possible a good chunk of that is not really just MDD, but it could be bipolar spectrum?
You know, I think that's true. I think that, just to back up a little bit, I remember, Andy, there was a gentleman that I had seen not too long ago, and he came into the clinic, and he had he tried on many medications, including neuromodulation, like TMS. He even had ECT. And not only did he have a persistent depression, but his depression had been so disabling. He was a truck driver, and he couldn't drive his truck. And he received intravenous low-dose ketamine on several of infusions and was well and was, frankly, in full remission. And he asked me a question, which was probably one of the most interesting questions I've been asked in a long time. He said, "Can I ask you a question?" I said, "Sure." He said, "Do I still have treatment-resistant depression?" I said, "No, you don't."
Because he wasn't depressed anymore.
I wasn't depressed anymore. And then I thought to myself, that's a very interesting question. And what he had he had inadequately treated, improperly treated, or drugs that weren't matching. The penicillin wasn't matching his bug-type depression. And so this moniker TRD came out in 1974. No one really knows who authored it. Some say the WHO, but no one really knows. And when it's been around for a long time, and I think it's pretty stale dated, quite frankly, and it's never really been validated, meaning it doesn't really capture a distinct group of people. There are people who are absolutely not responding to an anti-neoplastic if they have, say, a breast cancer or colon cancer. But we don't know that in depression. We have no knowledge of that. Second is that with respect to the guiding principles, I like what you asked, Andy. I mean, most people have either been incorrectly diagnosed and or are on inadequate treatments. And on the exam question says, what percentage of people who've been labeled as TRD are actually pseudo-TRD? And the answer is 50 to 60%. And they have got the wrong treatments, wrong diagnosis, et cetera, so forth. Now, nothing, of course, you're going to diagnose bipolar on mania, hypomania, but there are, in fact, we're really just lawyers in the courtroom trying to build the case beyond a reasonable doubt. And one of those circumstantial pieces of evidence that can kind of get your antenna up about bipolar is the patient says, I've had good trials, good duration, good dosing, and the antidepressant doesn't really help me. That just raises the question about, do you have the diagnosis correct? It doesn't, obviously it's not, prima facie evidence that you have bipolar disorder, but it does actually get you thinking about that. I mean, that's a very important point. But for me, I have always maintained a certain kind of optimism. I tend to have an optimism bias anyways, but I'm optimistic doing this for 30 years because some people do get better. And I have seen what the literature tells me what is going on. That is that these folks are often misdiagnosed and or have not been treated adequately.
Could not agree with you more. And what we see a lot out there is people who are probably monoamine resistant depression, if you will, who get SSRI, SNRI. And now that we have other options, and certainly we're either using, let's say, intranasal esketamine, even atypical antipsychotic augmentation, which is very evidence-based, people aren't doing it.
There was a survey came out called the World Mental Health Survey, which was authored by the WHO a few years back. And there's been a number of papers come out of it. Ron Kessler is a colleague of ours from Boston. We know Ron well, does a lot of population-based research. He looked at that data set, and of all people living with major depressive disorder who are experiencing a depressive episode, Andy, to your point, depressive episode is not equivalent to major depressive disorder, but it's the defining characteristic. 80%, 75 to 80% do not go on to a next step. They get an SSRI and they just flounder along for years and 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 years, and often at suboptimal doses. This is the modal situation 75% of the time in the World Mental Health Survey.
Amazing.
Roger, you've talked a lot about the implementation gap. And that's probably what we're talking about here is we do have evidence-based treatments, but they're not being implemented. How can we help cross that divide?
This podcast, for one.
I say this, I think it's a two-armed approach, Steve. This podcast for sure. Maybe one day ChatGPT. I'm going to make a prediction about extinction. This is not a very happy extinction, but it's an extinction nonetheless. I think that the near term, it's not unreasonable that clinical practice guidelines will be extinct. Why do I think that? Why would you go to a stale-dated clinical practice guideline that provides just no clarity on direction forward when you can just go on OpenAI and get a nice synthesis of the information? That's not fit for prime time just yet, but that's coming up. But what we need to have, Andy, again, some of the aspects, structural and systemic aside for a moment in terms of access, affordability, availability, all of that, those are obviously barriers to getting people on the right treatment. But that aside for a moment, I think, in fact, what we have is we have inertia, human inertia. We tend to be inertia, by nature. Second is that I think there's not necessarily a familiarity with some of the differences across treatments, and frankly, the evidentiary base. When I started as a psychiatrist 700 years ago, at that time, we didn't know what really the next steps were. The evidentiary base wasn't really adequate to inform, and I was always told when I started, medical student and resident, just try whatever works. But now times have changed. We actually have a reasonable evidentiary base as to what people should be doing for next steps. So in some defense, I can't defend it, but in some defense, people didn't really know where to go next steps, but we do now. And this is captured in some stale dated clinical practice guidelines, but it's the case now. We have therapeutics that are very well established as taking people to the promised land of remission and recovery if they can get on them.
Talking about stale guidelines, the APA's treatment guidelines for MDD have not been revised. 2010, exactly. Isn't that crazy? Well, let's move on a little bit here.
Well, the problem also is not 2010. How long does it take from the beginning of...
True.
That's when they're
probably
published.
2205.
That's
true. Very true.
Yeah, and I wonder if the APA is not just paralyzed by the sheer amount of information that's come out or something. I'm not sure why it hasn't.
I don't know.
But let's move on a second. We could certainly debate the merits of DSM-5 vis-a-vis DSM-4, but I think a couple of things DSM-5 did quite well here have to do with depression. In DSM-4, of course, we had something called a mixed episode, right, which was really a variant of mania. And you'd had to have full criteria for mania and full criteria for depression at the same time for at least a week. And that's just not how patients present. There's much more of a spectrum where they're either fully depressed or fully manic and everything in between. So DSM-5 introduced two important specifiers in my mind. One, of course, mixed features, and the other, anxious distress. And now for the first time, we could apply the term mixed to something that wasn't necessarily bipolar. You could have MDD, a major depressive episode from MDD, with mixed features. Let's talk a little about the anxious distress and mixed feature specifiers, Roger. What are their clinical significance?
Yeah, it's a great question. I think we all know as clinicians that patients with depression often are anxious. And the DSM authors back in DSM-5, circa 2013, updated to the TR version, the DSM-5 TR, wanted to instantiate or bring to reality a recognition that this is a group of people who have a much more difficult to treat, complex depression, whatever adjective we want to use. In other words, the illness is greater in its severity, it's longer in duration, they have more chronicity, higher risk of relapse, more suicidality, more comorbidity. Clinician after clinician knows that these folks are often more likely to over-endorse symptoms and over-endorse, in quotes, side effects. Now, obviously, it's another issue as well. And we can sort of conjecture what that's. Often the anxiety has been the antecedent to the depression, doesn't have to be, often is. Many would be familiar with some of these personality inventories like the Neo-PI and so on, where you look at personality along a dimension, and there's a concept called neuroticism, where people have a propensity to sort of negative, anxious states, and they tend to be overrepresented in that group. So the DSM said, enough's enough. We have to sort of bring this, give it its debutante, give it its time now. This is something clinicians have to consider. You mentioned heterogeneity, Andy, but this is also about trying to personalize the assessment, personalize the treatment selection, and inform your treatment selections based on the evidence that there are, in fact, a subgroup of our patients, a handsome subgroup, quite frankly, in size, who do meet the DSM-5 TR anxious distress specifier criteria, 2 or more of 5 symptoms in that polythetic list of anxiety-related symptoms. And the reason why we're asked to look for that is because of this is a very difficult situation for patients, and there are differences in how you might go forward from a treatment perspective.
Well, the thing I like about that is that the DSM didn't stick their neck out and say it, but who don't respond to SSRIs?
Right.
And what we found out is that these specifiers actually name them. Not that you never say never, you never say always, but basically, anxious distress responds to an SSRI about half as often as if you don't have it. So the drugs work twice as well if you don't have this. How about mixed features? They don't work. Sometimes they make you worse. So, if you have either of those two specifiers that we're talking about, that hangs on basically this is SSRI non-responsive syndrome.
Yeah, I think all three of us have been saying for several years now, these patients need an atypical antipsychotic that has evidence of efficacy for depression. And let's face it, not all antipsychotics are antidepressants, but some certainly are.
One of the things that hasn't happened is really good treatments that are at the level of approval for using atypical antipsychotics as monotherapies. So, they kind of back into it by having people that have residual symptoms and they're still on an SSRI and then they add them. That's sort of where we've gone. You wonder whether that's actually going to be necessary.
Andy, one thought I had just as we're having this discussion is that we have an appetite to know what are the best predictors that patients are going to respond to this treatment or that treatment. And of course, that's going to come hopefully to us in the near future. But I think we're probably better able at determining who's not going to respond. In other words, our probability of non-response prediction is probably better than our probability of response prediction. And so, Steve, your point, the person who's really, really anxious, the person who's got mixed features, certainly the patient who's psychotic, or the patient who tells us they have a trauma.
How about only one SSRI?
Yeah.
So that if it doesn't work, you give them a second and a third? Because now that actually is a signal. Hey, guy, Al, you prescriber out there, you're probably not going to respond to the second or third SSRI, SNRI.
100%. And also, these are not mutually exclusive, obviously, but a trauma history. So when someone says they have a trauma history, SSRIs, frankly, are just not doing it. So again, these are not mutually exclusive. So I think we're better able at predicting poor outcomes on the basis of some of these specifiers, anxiety and mixed, as you highlighted, Andy, but also trauma histories.
See, what I think is so great about these specifiers is that if you learn them in practice, it should give you motivation. This is why it's like, I can do something, you feel good because you have, it predicts that I'm going to have a response if I actually rally to that symptom complex. Whereas if you're just buried in a sea of unresolved symptoms and they've tried other medicines before, you say, oh, woe is me, am I going to help this person? But I get very turned on and optimistic when I see these specifiers manifest. I say, I can do something.
Yeah, I think what you said earlier is true. People end up chasing the symptoms. So they'll do an SSRI in one of these patients, doesn't work, I'll add a benzodiazepine.
Right.
When maybe if we could treat the core underlying issue here better. So, we're talking also about this major depressive episode. What I find important about the specifiers is they apply to the depression, whether it is an MDD or a bipolar depression.
Well, having said that, don't you think that it's possible these specifiers are a type of bipolar? Oh my God.
I kind of do. Yeah, my bias is we're in the bipolar stuff. You said years ago, Steve, there's not bipolar 1 and 2. There's bipolar 99, remember? Yeah. So it's a continuum.
Yeah.
I think it's just an artificial distinction we make sometimes.
And just to bring up a little history, we all love history. I mean, if Mel Kreplin was joining our podcast today, he'd say, I told you guys this 100 years ago.
I told you this.
That this is along the spectrum. So, he actually, this is before MTV, that video music station came along, but he already was ahead of this because he told us that if your mood is up, your thinking is accelerated, and your volition is up, your activity, you had mania. Your MTV on super steroids, your mania. MTV's down, you're melancholic. And he said, but the majority of patients are sort of a mixture. Mixtures of mood.
And they slide up and down over time between one appointment and the next.
Right.
The chances are, if you don't track that, you're not seeing these patients slide across that spectrum.
That's right.
All well said. So I think we all agree that these specifiers, anxious distress and or mixed features, are very important predictors of certainly non-response, but maybe there are some medicines now that are showing some evidence.
SSRIs.
I would say traditional antidepressants, or sometimes I call them traditional mood destabilizing or not mood stabilizing antidepressants. Because I think, this term about antipsychotics, which is, of course, a whole other discussion, but I think these drugs are really mood stabilizing antidepressants in some cases.
Yes.
It may fit them a little better when we're using them for mood states, let's say. Okay, let's see. But now let's move into treatment a little bit. So obviously one of the things we have to think about when we're choosing our treatments is the balance between efficacy and safety tolerability. So in these more complex patients, how does that enter into our thinking? How do we make that decision?
Well, I mean, the point's well taken. I think that always considering tolerability and safety, but also recognize that depression's a very unsafe medical condition. So you have to balance risk against this organism called depression. But yeah, I mean, there are certainly adverse events that we consider more tolerability problems, like gastrointestinal and sexual dysfunction, things of that nature with SSRIs and so on and so forth. But of course, we want treatments that are not going to be unacceptable to people in the sense of weight gain and metabolic disruption, prolactin elevation, or what we used to call as EPS or akathisia type phenomenon. So those are clearly aspects that one has to consider. We did a survey, Andy, as part of the DBSA, Depression and Bipolar Support Alliance. We asked people what do they prioritize in the treatment, and they put a tremendous emphasis on alleviating aspects of anhedonia, aspects of anxiety. And what do they not want? They don't want to have weight gain. They don't want sexual dysfunction. They don't want to have, obviously, these types of movement disorders. So kind of aligns with how I've always kind of seen it.
Well, Roger, you also published another interesting survey. The fact is atypical antipsychotics are underutilized for MDD.
Sure are, yeah.
The only drugs that really evidence-based FDA approved as augmentation for MDD are as of today, breaking news, we have 5 now medications. We had 4 yesterday. But lumateperone was announced, FDA approved as adjunct for depression. But yet they're still underutilized. And you published an interesting survey with HCPs, those who kind of were using them and those who weren't. What did you find?
Yeah, what we found, it's interesting, a colleague of mine, Emmanuel Wheeler in France, and I found that, there's 2 buckets, people who prescribe them, people who don't. And people who prescribe them for their patients, why do they prescribe them? Because they really, really work. And they help the patients in ways that are very meaningful. And then we ask the people who don't prescribe them, why don't you prescribe them? And they say, well, we're very concerned with side effects. And so, and again, these are not mutually exclusive, but the point being is that, of course, it's not one or the other. But to me, I think what it is that part of it is there's been a reluctance to prescribe antipsychotics. I agree with you, Andy, the name is terrible, it's stigmatizing, it lacks specificity, all of that. But at the same time, I think there has been reluctance. I think there's a perception that, and understandably so, that atypical antipsychotics may have greater burden of tolerability problems when compared to adding a bupropion or some other type of strategy. But the evidence actually does not align with that attitudinal bias. And the evidence actually aligns with a somewhat surprising message to some people, not to myself, because I've been involved in this, is that they're just as well tolerated. Whether you look at the type of adverse events, are they severe, are they serious, dropout rates due to side effects. In fact, we talk with specifiers. It turns out that people who have mixed or anxious type phenomenology or with a lot of agitation, they even do better on tolerability than adding a bupropion or some other antidepressant. So in fact, I'm not going to say that they're superior, but they're not inferior to what is perceived as a better tolerated, yet less evidence-based approach, adding a bupropion.
One of the things that you could maybe put in here that we don't do is deprescribing.
Yes.
And so one of the ways to mitigate perhaps some of the so-called long-term problems is to say, this is one of the problems. I mean, we're all guilty of that at this table. We haven't studied enough. When is it safe to see if you can stop something? But I think that the idea of giving an atypical antipsychotic for a lifelong illness and going to sleep at the wheel, maybe not the best way to do it. And one of the ways is to say, is there a prudent time in someone's life when things are stable and you've a year, 2 years, 5 years, I don't know what it is, but to withdraw it and to say over a slow taper whether or not someone doesn't need it anymore. And if they do, give it back or give another one in the class. You're playing with fire this way, but you're also playing with fire by going to sleep. How many of us go to a clinic and see everybody there that's on all sorts of things, including benzos and hypnotics and SSRIs that have been on for 20 years, and no one's asked the question, I wonder if I could stop this. So, as enthusiastic as I am for giving these medicines, I'm beginning to see my treatments as being increasingly medium term, not short term, but also not long term necessarily, unless you have evidence that the risk of an attempted withdrawal is greater than the risk of continuing medication. We should be first in line to start saying how much gratuitous prescribing is going on out there. And so we want to make sure that in this podcast we're not saying that, let's give this class of drugs and forget about it. Maybe others will come up. I think we've got, particularly on the mixed side, far too little evidence has been even generated for lithium. Lithium is a drug that's on a big comeback now, and I think that maybe that is and we understand the long-term ramifications of lithium pretty well.
Yeah, and I agree with that entirely, Steve. And just to that point, we do have an evidence base to support the 5 that have been FDA approved, Andy, that you made reference to. But I think there is a very relevant knowledge gap, and that is that what is the maintenance efficacy of atypicals when added to an index antidepressant in MDD? And the answer is we have 0.0 data to show positivity here. Very few studies even in the area.
And some of the studies didn't work.
Yeah, we had some failed studies.
Yeah, so I think, so it's a huge knowledge gap.
But wouldn't you agree the evidence base in bipolar, though, is a little stronger?
Yeah, we're talking MDD, for sure.
Severity.
Yeah, MDD. In bipolar is where I would see it quite differently, in the sense that I think that the standard of care in bipolar disorder is that indefinite treatment is recommended. That would be the standard of care.
Well, I think we have some evidence here about which patients are going to be more malignant and more chronic. Patients with MDD who start having more and more episodes. Then I would be a lot more scared.
I just saw something at a conference on schizophrenia that said the way to prevent really horrible outcomes is to not let any patient have his or her third episode. The Swedes, the Scandinavian evidence, once you hit your third episode, you're into a type of illness. I wonder, Roger, I've talked to you about this. What if we stop the third episode of depression?
Yeah.
And so, maybe people who have 3 or more, this seems to be a chronic, so if you're talking about major depressive illness, not bipolar,
right.
Maybe if you've had 2, you could, have a period of maybe a year or something or longer. Maybe those people don't need to be treated for a lifetime. Unfortunately, maybe if they've had 3 or 4 or 5 episodes, there's evidence your brain is actually got a hippocampus is rotten.
That's right. No, it does. It rots.
And all sorts of things. That's a different group. So, we might need to look at trying to prevent people getting into that.
Yeah, no, I totally agree. I want to go back to how you framed it, Roger. I thought it was great, which is, when we talk about risk, we think about side effects and safety issues. But what is the risk of inadequately treating these illnesses?
Well, I just said one of them, right, is to progress to a point of no return.
That's right. You get irreversible cognitive impairment, for instance. the canvas scars down.
Well, you've done some studies of that. We've had some co-lectures together over the years. And Roger has shown me that actually when you recover from second, third, fourth episodes, one of the symptoms that rarely recovers is the full cognitive battery. 100%. And that's sort of a fingerprint that you've had 2 or 3 episodes. And so the question is, can we prevent that from happening?
Yeah, I completely agree with that. I think that this is something in terms of advocacy, we're advocating for a better health outcome for people who have lived experience. And just as a comment, what I've noticed is that the benefit and risk of antidepressants has sometimes, but not usually, taken into consideration the cancer that depression actually is. And when you look at every statistic, locally, nationally, internationally, depression is the leading cause of loss of healthy life amongst the humanity. So I think that as part of the that designation, which is a fact of depression, unfortunately, doesn't seem to kind of moderate the benefit-risk relationship of antidepressants more than I think that it should. And so I think it's a cancer. I believe that strongly, doing this for as long as I've been doing it. And it needs to be tackled with the best available treatments. Again, we don't want people to have untoward side effects and so on and so forth. But I think that has to be considered. And, no one's unaware of the mental health crisis that's going on. Depression's not going down. And, but I think also, I agree with the point, Steve, around the deprescribing. And I do think that much of the damage that's done to the brain and body and the lives of people with depression and bipolar was completely preventable. And it would have been preventable. And part of it's not our fault. Part of it, people have access problems to health care, and they have barriers, and there's attitudinal barriers they have to seeking out health care and all of that. But for example, I talked about how patients just flounder along for months and years. That's unacceptable. Or they're on therapeutics that diverge from the best available evidence. And we see this all the time. In fact, the evidence shows that only 20% of adults with depression are receiving care that's called minimally adequate. 20%. So it's part of the knowledge gap, the implementation gap, but we can't blame everyone.
So we're manufacturing complex depression.
I think a lot of it is preventable.
Yes.
A lot is preventable.
And shame on us. One of the things that I think we should do is get urgent. I've got I just wrote an article myself about, again, I think this is true for chronic mental illnesses and schizophrenia the same. You know what it is? It's called time is brain.
Yeah. Mm-hmm. Oh, I agree.
And so, it's no problem. I can give a second or a third SSRI and then take 4 months or a year to give the next one. And then, we can always use, the big stuff. And, we can always come back to it. No, the brain is different a year from now. And, and the substrate's changed. And so it's an urgency. The brain's on fire. Right. And so with a chronic illness, at least certain people with certain trajectories, their brain is going downhill, and we've got to rescue it and get some urgency. So getting these symptoms over early so that they don't have their third and fourth episodes is something we don't even talk about.
Right. Well, Rakesh Jain and I published an article a couple of years ago looking at big prescriber databases for MDD. And one of the things we found many things that were shocking, I'll be honest with you, but one of them was, on average, people wait 8 months after starting like an SSRI before they do something. So to your point, there's an urgency gap here too, guys. I completely agree.
Time is brain.
Time is brain.
Time is brain.
100% right. And we used to think that, of course, for schizophrenia, but I think for mood disorders as well. We've got to think that way. I also think that we've got a problem with our expectations kind of get adjusted to what our medicines can do. And because SSRIs kind of only do so much, I think people have kind of gotten into a good enough is good enough mentality.
Right.
But we do have more evidence now. And you raised a point earlier. The most common augmentation by far in the U.S. is bupropion, which is not evidence-based. The evidence is actually very marginal.
Correct.
And it's not FDA approved.
Right.
And I kind of feel like maybe this is being Pollyanna. If you make a diagnosis, you should start with an FDA-approved treatment. At least there's evidence.
Absolutely, there's evidence, and there's substantial and compelling evidence. There's, when, Yogi Berra, so many great lines. He said, when you get to the fork in the road, take it. And when it came to depression, if the patient has an inadequate response to an antidepressant, we just said the next step is to take it. We kind of waffled. We didn't know what to say. You could add on, you could switch. There's been 3 big trials published in the last decade, sponsored by PCORI, in government organizations like the VA, where they've looked at this very question. And so these have been sponsored by non-pharmaceutical sponsors, taking adults with depression, inadequately responding, and the question, Andy, was posed, what is the outcome if they switch to a venlafaxine or bupropion versus adding bupropion versus adding an atypical?
It was aripiprazole, right?
Aripiprazole 3 times, all 3 studies, different studies. Right. The Ascertain study also included TMS as an arm. We have also the VAST depression study and a study of the New England Journal in a geriatric population authored by Lenzi et al. These 3 studies, at some point, data points become a pattern. All reported the same thing, that switching to a bupropion or adding bupropion was inferior to adding the atypical.
There you go.
So there you go.
Yeah,
and these were big studies, disparate populations, geriatric, younger, VA.
So why don't we pick up on that? If in infectious disease you had chronic bladder infections, you kept knocking down the bugs to only 50% of the bugs, you'd become treatment resistant to that antibiotic. Right. Let's take your cancer, let's just knock down, let's get half of it, the bulk of your tumor gone. Right. Nobody thinks that way except us.
Yeah, absolutely.
Totally agree.
Absolutely.
Well, I want to go back to, Roger, your survey you did with the healthcare providers, and we shouldn't be naive. I mean, there are legitimate concerns with atypical antipsychotics. But the group that was prescribing, it's fascinating. I always say people vote with their feet. And I think that the clinicians were seeing the evidence of efficacy, but I think the patients were also seeing it and telling clinicians. Now that we have, as of this morning, a medication FDA approved as augmentation for MDD, that being lumateperone, which has very low to no risk of some of these issues, weight gain, metabolics, movement disorders. Does that shift the risk-benefit analysis a little bit here?
I mean, it categorically does, and of course doesn't increase prolactin either. And I think it categorically does. And again, I think it begins with what's safe, what's effective, what's FDA approved. But the other point is, is to your point, I mean, when you're having that conversation with patients, or frankly, what's happening more and more is that patients are they're saying the heck with Dr. Google, that's passé. They're going right to chat, and they're typing it in. What the heck is this medication? Should I take it? They're hearing what the side effects. So clearly, I wouldn't want. Who wants those side? No one wants those side effects. So I think it does. It's part of the calculation, and it is clearly an advantage to people who are taking these medications.
So I think now, if we have medicines that are clearly efficacious, that have much less risk, and you mentioned it earlier, Steve. Our first 2 drugs approved for bipolar depression were a form of olanzapine and quetiapine. Well, that's a lot of weight and metabolic risk. But the newer ones, cariprazine comes to mind, lumateperone, have much less of those risks. I think that just has to fit into our equation, especially talking about what's the risk of inadequately treating the illness. How do these therapies also fit? What is the evidence base of using a couple of these atypicals in particular for the specifiers we talked about, anxious distress and mixed features?
Yeah, this is a great question, Andy. So if we look, again, focus on MDD, most of the work, and many of us have done this work together as colleagues, have gone back to data post hoc and looked at some of these studies and tried to see whether or not there's a suggestion of an anti-mixed or anti-anxiety signal. And we're seeing that for example, cariprazine. We saw that with mixed and also anxiety. We saw it with brexpiprazole, a reduction in depression, in anxious depression, and also with lumateperone. Lumateperone, you mentioned, is approved as an adjunct. It was studied separately in adults with, among other things, MDD with mixed features as monotherapy. So it's the only one that was studied a priori in that way. Now, the indication, Andy, you just made mention of that was just happened today, or at least announced today, that indication was based on 2 randomized, double-blind, placebo-controlled studies. And one of them, so-called 502, actually included the GAD-7 and looked at anxious distress and showed that the effect in the patients was significant in the 2 studies that were done in MDD, but in the anxious patients, the effect size went higher. So the effect size in the full samples was 0.56 to 0.61. That went to 0.59 to 0.85. So it seems like the anxious patients appeared to have a greater overall effect size improvement in depression.
Quite impressive. So what we're talking about is that we started this discussion with these complex patients, whether we're talking about symptom complexity, comorbidity complexity, and so on. We have evidence for some of these treatments. They can work in these complex patients we're talking about.
Most of it's post hoc, right? Okay. So, I mean, there are several atypicals that, at least post hoc, it will say, well, if you did or you didn't have anxious depression, you had the same outcome. Whereas SSRI, if you did or you didn't have anxious distress, you responded better if you did not have it.
Right.
Now, what about the mixed features? There's been a little bit more in terms of being proactive. Some of the medicines have done randomized prospective studies, but there's also post hoc analyses that suggest that the atypicals work in augmentation just as well if you have mixed features as if you don't.
That's right. Well, Steve, I'm going to ask you a provocative question.
Provoke away.
I'm going to provoke you. You mentioned earlier, if I have somebody on a traditional antidepressant and I augment with an atypical antipsychotic, going forward I could consider deprescribing the atypical. Why not deprescribe the ineffective antidepressant and continue the atypical antipsychotic?
Great proposal, and I think you're right. Let's do it. I mean, it'd be more benign. I tell you what, given the evidence we've said, what's holding that patient in remission, if they're there, may not be the SSRI. So if it's we were just wimps in the first place and weren't willing to switch, but add it, some of the evidence, of course, tells us to do that. Then why not? And see. I bet you get away with that a lot more than if you'd deprescribe the atypical.
Here's why I think you're right. I think either you're an antidepressant or you're not. Now, Roger, why are these atypicals approved as monotherapy for bipolar, but only as adjunct for MDD? Do they need hamburger helper?
Well,
I happen to have lived this story, but I want to hear your answer. I'll tell you.
Well, I mean, they a couple of responses, and I know, Andy, you've been involved in the research of most, if not all, these medications, but they were studied as monotherapy in bipolar depression, and the FDA's guiding principle is you get what you sign up for. So they signed up for that, that's what they got. And they were studied as adjuncts in MDD. Now, Andy, you know better than anybody else, quetiapine was actually studied way back in the day as monotherapy.
Do you know I'm first author of the first paper ever published of an antipsychotic as monotherapy for MDD? Quetiapine XR.
Quetiapine XR,
yeah.
absolutely.
And it worked extremely well.
It worked extremely well. And
now tell me, why was it not approved?
Well, back in the day, I mean, this was 15, 20 years ago, in those days, we didn't have antipsychotics that were void of weight increase and metabolic shifting and so on. And FDA landed on a position that they were concerned about the liability there. And so that affected, I guess, their deliberations and their decision. The FDA's mandate is safety first. And no one questioned the efficacy. So then implicit in that, or tacit to that, is if we can create treatments that are efficacious but missing or void of those problems or reduce those problems, that shifts the calculus.
Did quetiapine not also work as a monotherapy in GAD?
It did too.
Yes, and they didn't get approval for that for the same reason.
That was Cutler et al.
Here's what happened. I was with them. We went to the FDA. And we said, and of course, they were never going to market it as a first-line treatment. Right. FDA, maybe I'm being histrionic, the FDA freaked out. They literally freaked out. They said, oh my God, the risk, weight gain, metabolic. And so AstraZeneca had to come back and say, what if we do it as an adjunct? They said, well, then the risk would be justified. The easy-to-treat people would get an SSRI and so on. But with bipolar, of course, the risk is justified from day one because they don't have something else. So my point, back to the question I asked you, Steve, is either an antidepressant or you're not. And I believe these drugs would work very well as monotherapy for MDD. It's my bias because
I think you're right that one should consider deprescribing in all of our patients after chronic treatment all the time. I mean, that should be just put into our armamentarium of options. And if these augmenting antipsychotics are given and they responded to the second drug, then stop the first one.
Yeah, it's true. But also, Roger, it occurs to me, I think we've been thinking of depression as treating the acute episode.
Yep.
And so to your point, we don't have a lot of long-term maintenance studies for MDD per se. Bipolar, yes. Maybe we need to start thinking about this differently, not just as treating this as an acute thing. but as an illness.
Well, I agree with that. And I think that, going back to a comment moments ago, that we don't have a evidence base to support the maintenance efficacy of second-generation antipsychotics and MDD. And I don't necessarily believe that the absence of evidence is evidence of absence. We don't know. No one really knows. There has been some negative trials, or maybe they're failed trials, I don't know, in that area that looking at atypicals as maintenance. So for now, I think that, yes, I don't think lifetime. I think, Steve, to your point earlier, I don't think indefinite. I think it is a finite period of time and we reevaluate. And every patient's going to be different. But I go into this with a finite period, maybe it's 6 months, 12 months after they've achieved remission, something of that nature. But this is a great question. This question is one that we often are asked, and it's often one we ask ourselves. If the patient's getting better after you've added the atypical, why not just stop the antidepressant, leave them on the atypical? Someone has to do that study, right? That has to be done now, especially now that we have agents that are in the atypical category that are less susceptible to these types of side effect concerns. Someone has to do that study.
Well, the quetiapine XR studies we did as monotherapy, we did not have a long-term extension to them.
Correct.
Unfortunately, in my mind, because
one of the things I'd like to put in as an advocacy is taking, again, a chapter out of the book written in schizophrenia, which is that the duration of untreated psychosis is before the first episode is treated. The length of time you go without being treatment, it has a big impact on not only your brain size, but on your ultimate outcome. And also the amount of time that you're untreated after you've had your first episode is bad for the brain. It actually is degenerating, and then the treatability. We have none of those kinds of studies in depression, and if you look at it as a chronic illness, that not everybody. So some people are going to have that trajectory and other people are not. So you should do neither of these two things. After a while, treat nobody chronically, or after a while, treat everybody chronically. So we probably realize that there's a group that need it, and probably the risk-benefit for that group is justified. But, we're not going to know that unless we do the studies, and I actually think there's a certain common sense involved about deprescribing, at least the dual agents.
Based on that, I'd like to introduce a new term. I like DUP, duration of untreated psychosis. I think we should have DUD. DUD, duration of...
Yeah, Stephen, I'm talking about this.
Oh, well, we need to publish an article.
We haven't published it yet.
We're going to publish the DUD article there.
I agree with it.
Yeah. I'd like to go back, though, to the timing of all this is so important, and the regulatory aspects. Back in the day, this is, back in the late 2000s when we went to the FDA, this is a very different time. We recently had the articles being published about the weight and metabolic issue, ADA and APA published. Of course, the bolded box warning about mortality in elderly people. So, and you're right that the FDA's charge is safety. So I think they were acutely sensitive to that. We're in a different era now. We're a little farther away. Some of it's in the rearview mirror. We have some perspective. And it's a different regime, frankly. And my understanding is that they have had some discussions. It's very possible they would reconsider an atypical antipsychotic as monotherapy for MDD, and that lumateperone may actually be studied in that manner. So I think that would be interesting, but I think we're talking about some medicines, and now there's only 3 FDA approved to treat a major depressive episode, whether it's MDD or bipolar, that being quetiapine, cariprazine, and now lumateperone. So we have 3 medicines approved to treat what I would say is the syndrome of depression rather than the diagnosis.
Yeah, I know this monotherapy question. I mean bipolar disorder is on a spectrum, or certainly overlapping with major depressive disorder. That aside for a moment, they're different. They're overlapping but different, and we already have monotherapy indications for atypicals in bipolar depression. And you mentioned lumateperone; it's monotherapies indications BP1, BP2. And the safeties there. BP2 is a closer genetic cousin to major depression. BP1, especially when psychotic, is a closer genetic cousin to schizophrenia. So I'm not saying BP2 is the same as MDD, because I don't believe that, but they're cousins. And if it's safe in treating bipolar 2 as monotherapy, for me, I can drive home at the end of the day, leaving my clinic very comfortable knowing that an MDD patient's taken as monotherapy.
Quetiapine's the same story, but the risk profile is quite different. Guys, one of the things we didn't talk about when we talk about complex depression, and of course, one of the worst outcomes here is suicide. And we do have some treatments with some evidence of efficacy for suicide. You mentioned lithium, for instance. How should we factor suicidality into our assessment and treat patients?
Well, I think first of all, Andy, and this is something I've been thinking about for a long time. I think, the word for me is polysemous when a word means more than one thing. And suicidality is polysemous. It means more than one thing. I find it to be a completely useless phrase because suicidal ideation, suicidal behavior, and dying by suicide, they all sound the same. They are completely different entities. And we have this assumption that they're just contiguous, that one leads to the other. Again, not true. They're quite different. In fact, they're almost orthogonal to each other. They're very different phenomena. They overlap, but they're quite different. And the second part is how these things are coded and captured in the real world is so variable and so mixed. And so I think that the suicidality piece is one that's been a bit confusing. Thirdly is that it's possible that a treatment could maybe exacerbate ideation, but also reduce suicide. That's possible because they're very different entities. Yeah. So for me, the way I look at it is, and of course we know about this emergence of suicidality. Again, whatever that usually means ideation in behaviors, broadly defined in younger people under the age of 25. But since that box warning came out, that it was called the black box back then, it's 20 years ago plus, there's been many thorough, rigorous attempts to really get to the bottom of this, and there still is not any evidence that actually is causative. So association, everything that's causative is associated, but not everything that's associated is causative. And so we are still left with this sort of maybe younger population, and I've always thought it's youth, maybe with subsyndromal bipolarity at risk, thing in that area. I mean, I think it would be not, my own personal view is I haven't closed the door to the possibility that a drug could be a variable associated with worsening of suicidal ideation. We have dozens of drugs that have this in their package inserts. But again, that's not cause and effect. And that's, some might say, well, you're splitting hairs. No, we're not splitting hairs. There was this guy, Austin Bradford Hill, good British man, Austin Bradford Hill. And he had the crazy idea. He said, I think that smoking cigarettes causes cancer. Everyone said, no, it doesn't. It's associated. Well, he showed it causes. And we go through his 9 viewpoints, as he called them, which are the scaffold that we use to leap from association to causation. If you go through the 9 viewpoints of Bradford Hill, you got a tough case to make that antidepressants cause suicidality. That's a tough case to make. And the stronger cases, they reduce suicidality.
Well, I want to first highlight what you said. I think a lot of the box warning, when they talk about suicidality in children, adolescents, and young adults, they define young adults as 24 and under. And coincidentally, Barbara Geller and colleagues work at WashU said, if your first episode of depression is 24 or under, that triples the odds you're bipolar. Right. And so a lot of the people in this database, which is mostly SSRIs, were unrecognized bipolars.
Actually, box warnings cause suicide because they prevent people from giving antidepressants and treating children. I'm being a little...
Well, but,
you know what also causes suicide, probably, or at least high association? Being arrested the first 24 hours, being discharged from a psychiatric hospital, particularly in the first 24 hours. Those are very strong associations. And so, of course, people are going to get arrested, and people who run jails should probably pretty much know you have to watch people carefully. And also, you got to eventually discharge people from hospitals. So making sure that not medicines, but support systems are in place so that people actually who leave have some sort of help in the transition where the suicide risk is very high.
We know the FDA is a blunt instrument. It was always seemed strange to me that they tarred and feathered the atypical antipsychotics with this warning. Rick Weissler and I sub-analyzed the quetiapine data and found a decrease in suicidality being treated, and that's actually been seen with other atypicals. So
certainly clozapine for sure.
Clozapine is another great antipsychotic.
So there you go. With lithium is something to consider because that has not suicidality, that is suicide. But there's a problem with lithium in that. Don't stop it, and don't stop it precipitously, because it comes roaring back if you inadvertently or patients run out of it and so forth. So that be careful about deprescribing lithium to people with suicidal risk.
Well, you know, of course, the three of us were trained early on that lithium was a very appropriate augmentation agent for MDD. We would never argue about lithium's utility in bipolar. But it occurs to me that adding lithium, and we haven't talked about that as an adjunctive treatment for MDD, is a very reasonable thing too.
Wait a minute. Isn't MDD with mixed features or MDD with anxious distress maybe proxies for some form of in the spectrum of bipolar anyway?
Yeah. Yes.
Oh, maybe they're the ones who need it.
Maybe they're bipolar-ish, if you will, yeah. Great. Well, let's talk real quickly then about, let's sort of wrap up here. Yeah, we're getting close to the time here. When we're talking about bipolar, Roger, I just want to highlight one thing. There have been a couple of articles recently that suggested that the combination of an atypical with a mood stabilizer was even better than atypical alone in preventing relapse. So it's not always deprescribing, and sometimes we do need to use combination.
That's true. One of the aspects of both interpreting and drawing inferences from that, you cited it accurately. These are studies where people added atypical to lithium or valproate, and then the atypical is discontinued. But what's not been looked at is atypical monotherapy, right? Yeah. And so, and given what we know about long-acting injectables and bipolar disorder, et cetera, and there are recurrence prevention data for atypicals as monotherapy, actually. So I think the jury is still out. First of all, we don't use much valproate much anymore. The teratogenicity it's been revised. It's much more than we thought. But I do think that, in my view, in the United States, antipsychotics as a class are the most frequently prescribed class of medications in bipolar in many surveys. So they've become not de facto and de jure, they are the cornerstone mood stabilizers for bipolar disorder for a variety of reasons. And so we know they're the cornerstone in treating schizophrenia, but they become cornerstone in bipolar disorder as well. So I actually, I see lithium, I see lamotrigine, yes, and I see not all of them, but select atypicals with FDA indications, yes, as in quotes, mood stabilizers. Valproate's kind of, I've put valproate aside. I don't use it much anymore.
Yeah, and it's a shame, too, that the FDA is continuing to require either lithium or valproate as your augmenter for these trials that we're talking about. We need studies with lamotrigine. I completely agree. Lamotrigine is the one mood stabilizes from below. Yeah. We don't have a lot of data. We don't have any data that I know of, Roger. Lamotrigine augmentation for MDD.
No, we don't. You're right. So lamotrigine was looked at preliminarily in MDD, but not to the extent we would call rigorous. You're right, Andy. In fact, notwithstanding how much it's prescribed, and it's a very nice drug for bipolar depression, treatment prevention, it hasn't been even studied as part of, pivotal trials with antipsychotics until now. So, we know cobenfy is xanomeline trospium, and it's indicated in schizophrenia. So the Balsam program has started where it's being added to either lithium or valproate or lamotrigine in the treatment of bipolar mania or mix. So that's going to be the first development of lamotrigine with an atypical for an acute indication. We'll see what happens.
And it actually goes to Stahl's Rule 37, which is that when you have an effective antipsychotic, you get bipolar mania for free. They almost all work. And so I would imagine that work. Well, they work in the depressed phase, that's something else. But
this is my saying. All antipsychotics are antipsychotic and antimanics, most likely. They're not all antidepressants, as we've said. Well, guys, we need to wrap up here. We've been talking about complex depression, both unipolar and bipolar. What would be some take-home messages, Roger? What should we leave our audience with when thinking about assessing and treating these kind of patients?
2 points, Andy. First, let's get the diagnosis timely. Let's get it accurate. Second point is knowing, doing. We have to close the gap between what we know and what we do. We have an appetite for innovative therapeutics. That's important for the field. But if we can close the knowing and the doing gap, that is implementing what's already FDA approved, evidence-based, in clinical practice guidelines, that would make a heck of a difference and beat this 20% rate of minimally adequate treatment currently going on.
Well said. Steve?
Urgency to treat and urgency to stop treating. Okay. So I think both deprescribing after a while, particularly like you cleverly said, Andy, that's pretty good on your part, stopping the SSRI first. Every once in a while. And then making sure that the brain's on fire and having this urgency, the idea to get cracking and get these people better.
Yeah. I couldn't agree more, and I think It's very important to see these people as individuals, to assess the whole range of symptoms, comorbidities. Try as much as possible to use Occam's razor. Try to use a really effective foundational treatment that treats as much of these range of symptoms as possible, and then be very rational in what it is you're going to be adding on. Well, guys, thanks so much for your time. This was really terrific. Thanks, Steve. And thank you, Roger.
Andy, been a lot of fun. Fun to do this with you and Steve.
Thank you for listening. And for more information about our podcast and our other educational products and services, please go to our website, neiglobal.com. Thank you.
Thank you for your participation in this CME NEI podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to print your certificate. This concludes the CME podcast presentation. For more information about NEI and our premier educational content, please visit neiglobal.com.